There are moments in anesthesia that define you. Moments where the monitors tell you something is wrong before you fully understand what. Moments where your training either shows up or it doesn't. Today, we're talking about one of those moments. Rare enough that you might never see it in your career. Deadly enough that you need to know exactly what to do if you do. I'm Anesthesia Buddy, and today, malignant hyperthermia. Let's get into it. It's a routine case. 19-year-old male, healthy, athletic, no significant history, coming in for an elective knee arthroscopy. You induce with propofol. You give succinylcholine for intubation. You turn on sevoflurane. Everything looks fine. Then, 30 minutes into the case, your end-tidal CO2 reads 55. That's high. You increase the minute ventilation. It stays at 55. Heart rate, 118. Was 72 at the start of the case. You check the circuit. No rebreathing issue. Soda lime looks fine. You increase ventilation again. Heart rate, 126. Temperature, 38.4. It was 36.8 when you checked 30 minutes ago. ETCO₂, still climbing. 70 now, despite everything you've done. Heart rate, 134. Blood pressure creeping up. 158/92. You reach up and feel the soda lime canister. It's hot. And that's when it hits you. Malignant hyperthermia, MH, hypermetabolic crisis of skeletal muscle, triggered by volatile anesthetic agents and succinylcholine. You used both today. The underlying mechanism, a mutation in the ryanodine receptor, RYR1 gene, autosomal dominant. What happens? Uncontrolled release of calcium from the sarcoplasmic reticulum. Skeletal muscle goes into overdrive. Uncontrolled sustained contraction. Massive oxygen consumption. Massive CO2 production. Massive heat generation. The classic signs you're seeing right now: unexplained rise in end-tidal CO2. This is your earliest sign, the first thing that tips you off. Tachycardia. The heart is working overtime trying to keep up with the demand. Hyperthermia, temperature rising fast, can hit 40, 41, 42 degrees Celsius. Core temperature rising faster than you can cool it. Muscle rigidity, masseter spasm after succinylcholine is a red flag. Isolated masseter rigidity should make you think MH immediately. Mixed respiratory and metabolic acidosis on your ABG. CO2 through the roof, pH dropping, hyperkalemia, myoglobinuria, dark urine, rhabdomyolysis. This is a true anesthetic emergency. Mortality without treatment historically over 70%. With Dantrolene, under 5%. That number only works if you move fast. Here is exactly what you do, right now, in order. Step 1. Call for help immediately. You cannot manage this alone. Someone needs to mix Dantrolene while you manage the patient. Get your team, get your attending, get everyone. Step 2. Stop the trigger. Turn off the volatile agent, now. Succinylcholine is already gone, but sevoflurane is still running. Turn it off. Switch to a clean anesthesia machine if available. If not, crank fresh gas flows to 10 liters to flush the circuit. You can maintain anesthesia with IV agents, propofol, opioids. Keep the patient asleep, but get off the volatile agent immediately. Step 3. Dantrolene. This is your antidote. This is the only reason MH survival rates improved. Dose, 2.5 milligrams per kilogram IV. Push it fast. Repeat every 5 minutes until symptoms resolve. No maximum dose in the acute setting. Most patients need between 2.5 and 10 mg per kilo total. Some need more. Dantrolene works by blocking calcium release from the sarcoplasmic reticulum. It stops the uncontrolled muscle activity at the source. Know where your Dantrolene is before this happens. Every OR should have it stocked. Know the location. Know how to mix it. Each vial is 20 milligrams reconstituted in 60 milliliters sterile water. It takes time to mix. That's why you need help. Step 4. Treat the hyperkalemia. Calcium chloride or calcium gluconate, sodium bicarbonate for the acidosis, insulin and dextrose if needed. Step 5. Cool the patient aggressively. Ice to the axilla and groin. Cold IV fluids. Cooling blankets. Target temperature below 38.5. Stop cooling at 38 to avoid overshoot hypothermia. Step 6. Treat arrhythmias. Avoid calcium channel blockers. They interact dangerously with dantrolene. Amiodarone is your friend here. Step 7. Foley catheter. Watch that urine output. Dark urine means myoglobinuria. Aggressive hydration to protect the kidneys. Target urine output 1 to 2 milliliters per kilogram per hour. Step 8. ABG, electrolytes, CK levels. Monitor continuously. CK will rise dramatically and peaks around 12 to 24 hours. Step 9. Call the MH hotline. In the US, 1-800-MH-HYPER. 24 hours a day, 7 days a week. They will talk you through the management in real time. Use this resource. Step 10. ICU admission. This patient is not going home today. MH can recur within 24 to 48 hours. Dantrolene continues postoperatively. 1 milligram per kilogram every 6 hours for 24 to 48 hours. The board question hiding in this crisis. They will ask you about the earliest sign of MH, not temperature, not rigidity, not tachycardia. Unexplained rise in end-tidal CO2. That is your earliest sign. That is what tips you off before everything else goes wrong. And they will ask you about the mechanism of dantrolene. Blocks ryanodine receptor-mediated calcium release from sarcoplasmic reticulum. And they will ask you what you do not give for arrhythmias. Calcium channel blockers. Dangerous interaction with dantrolene. One more thing. After this patient survives, and with fast treatment they will, they need genetic counseling. Their family members need testing. The ryanodine receptor mutation is autosomal dominant. Their siblings, their parents, their children, all at risk. MH doesn't end when the crisis ends. Know this drug. Know this crisis. Know where your dantrolene is before you need it. You watch this today because you care about getting it right. Because somewhere out there is a 19-year-old going in for a routine knee scope, and the provider in that room needs to know this. Maybe that provider is you. If this helped, share it with someone who needs it. And if you want to be ready for the next crisis before it walks through that OR door, subscribe to Anesthesia Buddy. Because the best time to learn this is before it happens. Stay sharp. See you in the next one.